Good afternoon, everybody, or anybody who's tuned in today. My name is Dr. Jamie Mitchell. I am the Senior Surgeon and the Medical Director of the Norman Parathyroid Center in Tampa, Florida. We are the busiest and highest volume parathyroid surgical practice in the world. And I'm also Director of the Parathyroid Division at the Hospital for Endocrine Surgery, where we operate. This is the only hospital dedicated entirely to the care of the endocrine surgical patient. A couple comments before we begin with some of our questions. The anatomy and embryology of the parathyroid glands is such that parathyroid surgery can be very sort of nuanced and complex. For example, the parathyroid glands are not always in the same place. There can be quite a bit of variability where these glands are located. The areas of the body that they are located in, most commonly the neck and the chest, are delicate areas. Surgery and navigating surgically through the tissues of these areas of the body is complex and can be challenging. And so without a lot of experience, it can be difficult to be successful when surgically treating this disease. And most of the surgeons in this country who perform parathyroid surgery don't have a lot of experience with this. And while they all do the best they can, because of this, a number of these operations end up being unsuccessful. And a significant part of my practice is taking care of reoperative surgery, parathyroid surgery patients who have had surgery that have been unsuccessful elsewhere. And one thing that I've noticed is a lot of patients after an unsuccessful operation, in many instances, are not really given a plan. They're just sort of left kind of hanging without knowing what else to do. Some of them find their way to our practice, but I suspect that many do not. And so I decided to do this Facebook live program in an effort to try to let people out there who find themselves in that situation know that there are options for you if you have had an unsuccessful operation and aren't being given any sort of guidance on what to do next. So having said that, I'm going to start going through some of the questions that have come in related to reoperative parathyroid surgery. So the first question I have is it more challenging to locate parathyroid glands during reoperative surgery? The answer to that is absolutely. There's a couple reasons for this. Now, it's always more difficult to reoperate in any part of the body, frankly. The neck is no different because, the body doesn't really like to be operated on. This is essentially, we're performing controlled injury to the tissues when we operate on you, and that sets off all sorts of inflammatory responses and healing, etc. And there's consequences to that. As a surgeon, you learn how to navigate through tissues surgically by knowing how the tissues look, how they feel, how they move in relation to each other. And after an operation, all of this changes. So the tissues look different, they feel different, they move differently with relation to each other. And so it makes it more challenging, to navigate through those spaces surgically a second time. Specific to parathyroid reoperations, the parathyroid glands are they're really small. Normal parathyroid glands are about the size of a lentil, and parathyroid tumors are not that much bigger. An average tumor is about the size of a lima bean, maybe. So when you have the added challenge of the distortion of the tissues that we're used to operating in, it makes finding these small structures much more difficult, while keeping the things in those areas of the body, like the neck, safe. Okay, we're going to move on to the next question here. This question is, what are potential reasons for persistent hyperparathyroidism after initial surgery? Well, there's really one reason for this, and that's because a abnormal parathyroid gland is not identified and removed during that operation. There can be a couple reasons for this. Sometimes Surgeons will perform focal parathyroid operations, and they'll use intraoperative hormone levels to predict whether that's the only bad gland or not. And while this can be successful sometimes, there have been a number of studies, including one that I did while still at the Cleveland Clinic, that show that a significant number of patients will have abnormal glands not found if you rely only on these intraoperative hormone level data. Sometimes glands can be in difficult locations and hard to find. Parathyroid glands, as I said, have complicated embryology and anatomy, and they're not always in the same place. And sometimes they're not even in the neck where we can sort of get to them surgically. And so sometimes glands or abnormal glands in these ectopic locations, it can be a challenge to identify them or find them, especially if they haven't shown up on imaging studies before surgery. Having said that, the majority of patients that I reoperate on have abnormal parathyroid glands that are frankly in typical locations. They're not in ectopic spots, they're not outside of the neck. They just were not identified, usually by a surgeon who just isn't very experienced at doing these operations. All right, next question. What is the likelihood of recurrent hyperparathyroidism after reoperative surgery? The likelihood so the difference, there's a difference between persistent and recurrence of this disease. Persistence is when you have an operation and you continue to have the disease. Recurrence is if it develops again down the line. If you have what I consider to be, the proper operation, the first time you have surgery, meaning all 4 parathyroid glands are evaluated and identified, recurrence is really unlikely. It's possible. We do see people come back 10 or 15 years later who had a good operation and develop another tumor. It does happen, although it occurs less than 1% of the time. Pretty rare. If the glands are not all evaluated, like a lot of surgeons in this country do focal parathyroid surgery and don't look at all the glands, you have a much higher chance of developing recurrence within a few years if that's the case. What is the likelihood of developing recurrence after successful reoperative parathyroid surgery? I would say because the approach to reoperative surgery is a bit different, at least in this practice, for a normal operation, we will always try to identify all 4 glands and evaluate them all. For a reoperative surgery, because of the added difficulties that I mentioned before, often we'll be a bit more focal. If we know where the problem is or which gland is the problem, often we will only operate on that gland and remove it without looking at the others. And because of that, if they've never been evaluated before, there might be a bit higher risk of developing recurrence. So here's another question. If I go forward with another parathyroid surgery, is it really possible my symptoms can be permanently resolved? I'm left feeling doubtful after my previous surgery was not successful. The answer to that is yes. Patients with hyperparathyroidism very frequently have a constellation of symptoms which can be pretty debilitating. And the majority of patients with successful surgeries feel better. The symptoms, either all or a majority of the symptoms will improve or resolve. It's one of the great parts of taking care of parathyroid patients is hearing from the patients a few weeks after surgery about how great they feel and how they've gotten their life back. This is no different with a reoperative surgery if we're successful. So I would say the answer is a definitely yes, although success is a bit more challenging when it's a reoperation. Here's a question from a patient who says that they've had 4 surgeries, I'm assuming unsuccessful surgeries. Is there anything else that I can do? I'm managing my kidney stones. Are there any scans that I can have done? The short answer is, yeah, there usually is something that can be done. Having 4 surgeries, obviously, it's a very complicated situation. Typically, when you've had that much surgery, we're limited a little bit in terms of proceeding with another operation if we don't have imaging tests that really are clear in terms of which gland is the problem. For the reasons I mentioned earlier, reoperative surgery is much more difficult, and after 4 surgeries, blindly reoperating in that scenario can be very difficult and often not successful. So we prefer to have, a positive imaging test, an imaging test that suggests pretty clearly where the problem is. If you've had scans or imaging tests since those surgeries that have not shown anything, that does not mean that they never will. We often will repeat imaging tests periodically every 6 months to a year. And the reason we do that is because even though imaging tests are unhelpful now, often with time that will change. The tumor gets larger, becomes more active. These are the thoughts or what we think might happen, such that negative scans become positive and helpful in the future. So repeating imaging tests is the right thing to do periodically. The other thing I would just say is that here at our center, our imaging tests really have been optimized. Imaging for abnormal parathyroid glands, the sensitivity just isn't very good. The technology isn't great for imaging, abnormal parathyroid glands. And ours are no different. They're not perfect, but we've really optimized them because of how many we've done over the years. And so I will say that patients who have had scans that have not been helpful elsewhere, we've been able to really localize their disease with our imaging tests here. Not a guarantee, but it's worth considering. Okay, here's another question that just came in now, I think. How do you diagnose parathyroid disease is still persistent after an initial surgery? Really, this is all based on your lab values. If you're hypercalcemic, you have a classic diagnosis of hyperparathyroidism, you have an operation, obviously we would expect your calcium levels to drop, and this happens quite quickly. Your calcium should be normal or even low, actually, within 48 hours of your operation. So if you have post-op lab work and your calcium is still elevated, and your parathyroid hormone levels are even in the mid to upper normal range, and certainly if they're also still elevated, that indicates that you still have a problem. Again, if you've had an operation and all of your glands have not been identified, then this is something that needs to be considered going forward. Okay. Here's a question that just came in. Can you have a normal parathyroid scan at the time of the thyroid surgery, yet later develop issues with the parathyroid glands? The answer is absolutely yes. I'm assuming this is a thyroid surgery, not a parathyroid surgery. But as I said before, imaging studies and the common imaging tests that are done for hyperparathyroidism are called sestamibi scans. It's a nuclear medicine X-ray. 4D CT scans are performed, and ultrasounds of the neck. These are the most common scans that are done, or imaging tests done, to try to see or identify an abnormal parathyroid gland. The problem is none of these tests have a very high sensitivity. The technology simply doesn't exist, even in 2023, for reliably imaging or being able to see abnormal parathyroid glands, even when they're there. Again, the sensitivity is maybe 50 or 60% for all of these tests. It has nothing to do whether you have hyperparathyroidism or not. The diagnosis is based entirely on your blood tests. Again, these are neuroendocrine tumors, and so they overproduce parathyroid hormone, and this changes your biochemistry in a very specific way. So whether we can see them or not on imaging, we know that you have a parathyroid tumor based on your lab tests. And this is a problem that patients often have. They are uncomfortable sometimes going to surgery for a tumor that we've never seen. But we know that you have one because of the way the biochemistry works. And it's, again, all based on your lab tests. Okay. Here's a good question. How can a doctor determine whether elevated parathyroid hormone levels are due to an adenoma, meaning primary hyperparathyroidism, or due to chronic kidney disease? This is an important distinction between primary hyperparathyroidism, which means one or more diseased or overactive parathyroid glands, usually due to an adenoma, as the question states, versus secondary hyperparathyroidism, of which there are several things that can cause this. Secondary hyperparathyroidism refers to a elevation of parathyroid hormone levels that frankly are not related to diseased parathyroid glands. They're actually doing their job normally. They're just working harder than usual due to some other influence in your body. Chronic kidney disease or severe renal failure, end-stage renal failure in patients on dialysis all develop secondary hyperparathyroidism. The physiology of renal failure really stimulates your parathyroid glands to work overtime. The big difference is that in primary hyperparathyroidism, your calcium levels become elevated. In secondary hyperparathyroidism, specifically that related to chronic kidney disease, your calcium levels are usually low. And so usually the distinction biochemically is pretty easy to make. Here's sort of a general question. At your center, how soon can a consultation be scheduled after you receive all the medical documents? In most cases, you will be set up to have a consultation with one of our surgeons within 7 days of all the records being received. Okay, so things usually move pretty quickly and efficiently, and it shouldn't be a very long wait. Let's see. Oh, great question. This just came in. If calcium is high and vitamin D levels are low, would you recommend taking vitamin D now or waiting until after surgery? Great question. So how does vitamin D relate to all this? If you have hyperparathyroidism, meaning you have overproduction of parathyroid hormone, you almost always will have low vitamin D levels. The reason for this is really how parathyroid hormone works. So the reason you secrete parathyroid hormone is if your calcium levels are too low in your bloodstream. Okay, these levels fluctuate within a range, but if they get too low, that's really the only job your parathyroid glands have. They sense this concentration of low calcium and they secrete parathyroid hormone in response to this. Parathyroid hormone does really three main things to then raise your calcium levels back up to normal. One of them is it converts vitamin D to its more active form. So it converts 25-hydroxyvitamin D to the more active 1,25-dihydroxy form. When you're overproducing parathyroid hormone, you're constantly converting that vitamin D to its more active form, and so 25-hydroxyvitamin D levels are almost always low. That's usually the level that your doctor will check if they're just checking a general status of your vitamin D levels. And I see this mistake made a lot. A patient will have classic labs for hyperparathyroidism, meaning high calcium and high PTH values, and their doctor will put them on vitamin D to try to correct their high calcium and high PTH. While vitamin D deficiency can cause elevation of your parathyroid hormone levels, that's a secondary hyperparathyroidism like I was speaking of earlier. Low vitamin D levels never, ever cause hypercalcemia. So if your calcium is high and your doctor says, let's try to fix this by giving you vitamin D because your vitamin D is low, please don't do it. Great question. Let's see. Here's a good question. If PTH never goes down to normal after parathyroidectomy, but calcium remains normal, would that be considered cured or not? Usually, it means you're okay. The key here is what your calcium levels are doing. So if you have classic biochemistry for hyperparathyroidism with high calcium, you get an operation and your calcium goes down to normal, but you have a PTH that's still a little above normal or even moderately elevated. That usually is okay. As I mentioned before, there can be secondary causes for your parathyroid hormone levels to be elevated. If your vitamin D is low, which it often is when you have this disease and it takes a while to recover. So that can stimulate a little extra parathyroid hormone secretion, even though your disease has been corrected. There's also a phenomenon where your skeleton, I didn't mention it before, but one of the ways that that parathyroid hormone raises your calcium levels is it essentially tells your skeleton to dissolve itself. We all have cells that live in our skeleton that are usually dormant, but they are activated by a parathyroid hormone. They are called osteoclasts, and all they do is dissolve bone mineral. And that's one way that you release extra calcium into your bloodstream, raise your calcium levels. When you have hyperparathyroidism, this is happening all the time. That's why people get osteoporosis. After successful surgery, that process reverses itself instantly, and usually bone density goes up. The skeleton, once it can, really starts to siphon calcium out of the bloodstream back into itself in some patients, which really lowers your calcium levels in the short term. But this process can go on for a period of time, and that so-called bone hunger can stimulate extra parathyroid hormone secretion to try to compensate for it after surgery. So usually the key here to the answer to this question is, what are your calcium levels? If they're still elevated, meaning above 10, and your PTH is elevated, that means you still have a problem. If your calcium has gone from clearly elevated to normal, but you still have a little bit of a PTH elevation, that's usually okay. Let's see. Here's one. Can calcium levels really change a lot from day to day? Mine went from 11.1 to 9.8 within just a few weeks. How is this possible? The answer is yes. Calcium levels can fluctuate pretty significantly in a relatively short period of time, especially if you have hyperparathyroidism. It's not that uncommon to see that pattern. A lot of things affect your calcium levels, it's just a concentration. So, for example, if you get really dehydrated one day versus being really hydrated another day, this number will go up and down. The other thing in terms of the fluctuation that we see is because parathyroid tumors, the tumor cells don't really follow the rules. And so in many cases, the hormone secretion is not in a very sort of steady pattern. It can be very, can fluctuate quite a bit, where there's really tremendous secretion at one point, and it can go down and go up, etc. So fluctuating values like this is pretty common. Don't be fooled by having high calcium levels followed by a normal calcium level and have your doctor tell you that you don't have a problem after all. Usually it still means you do. It's not uncommon to see these fluctuations even down into the normal range, like with this patient, when you have hyperparathyroidism. One more. All right, we have time, I think, for one more. Here's kind of a general question. What do the experts think causes our parathyroid glands to develop tumors? It's a good question. In most cases, the truth is we don't know. There are a couple things that we know that cause the development of hyperparathyroidism or parathyroid tumors. One is if you get treatment-type ionizing radiation to the neck that includes this field of the parathyroid glands. Mantle radiation treatment for Hodgkin's lymphoma is sort of a good example of this, where that area of the body is radiated. And so radiation to these glands can cause tumors to form. Usually there's a latency period of 10 to 15 years, though. The other thing that can cause the development of hyperparathyroidism is the long-term use of lithium. This is usually used for bipolar disorder. If you take this for many years, it can cause hyperparathyroidism. It's known to do that. In the absence of those two things, it really, we really don't know. In most cases of this disease are sporadic, meaning it just happens, and if there's a reason for it, has not been discovered yet. That's all the time we have today. That went by pretty quickly. Thanks to everybody who joined. For those who didn't have their questions answered, or for anyone else out there who has other questions, we will plan on doing another program like this in the future. So look out for it.